Good afternoon, everybody. Welcome to another episode of Coffee with Clinicians. Good morning, Dr. Serena. This is Cindy Gillum, your wound care nurse from EO2. And I have the esteemed Dr. Thomas Serena with us. I have known and followed his career for quite some time. He is the founder and director of the Serena Medical Group and research portion within that group as well, and is quite a known figure in the wound world, if you will, and is definitely a mover and shaker. I would consider you of the wound care specialist, one of the Renaissance guys who isn't afraid to do research and isn't afraid of new therapies. So do you have anything to add to that, Dr. Serena?
And no, I couldn't say it better myself. My mom couldn't say it better. That's great. So that's fabulous.
So I brought you on because you do have some experience, a lot of experience with oxygen. Can you give some examples as to how oxygen works in wound healing?
So, I grew up with hyperbaric oxygen. So that's high level oxygen that you breathe in, and then it's sort of inside out. But oxygen is important in a lot of different aspects, and people get confused between hyperbaric and topically delivered oxygen. Topically delivered oxygen works in a very different by a very different mechanism. So I'll focus on topical, and I think there's a number of different mechanisms. One that I think is very important is the antimicrobial action. You need to have a certain amount of oxygen present within the wound bed in order for the immune cells, the neutrophils and the macrophages to work. So in order to clear out infection, you need to have oxygen present in the wound. In addition, we're still learning about other things that topical oxygen does. It definitely changes the microbiome as well as having an antimicrobial effect. And also, it seems to promote angiogenesis. It may not do so to the degree that hyperbaric does, but it's still important. It's still an important part of how it works.
And on that topic, why do you not think that it is a competitor to HBO or hyperbaric oxygen? Because we do get a lot of physicians who have hyperbaric oxygen chambers within their wound care facilities, and they often see us as a threat to that.
I've never seen it that way. So oxygen is an interesting drug, if you will, or in this case, we're approved as devices. I shouldn't say drug, but anyway. But oxygen is an has interesting pharmaceutical properties. So and one of the really interesting things about it is that when people write for it, prescribe it, like doctors, they don't think about the mechanism of action, how it works, and design that to meet the disease. They memorize. I mean, people like me, we memorize. Oh yeah, here's the indications for HBO. Here's the indication for topical. We memorize those things, but I find that people don't think about what am I doing. So I have this wound. It's not a Wagner 3. It's a lower diabetic foot ulcer, and maybe it has a little bit too much biofilm, a little too much bacteria present. And what I want to do is do something underneath the total contact cast, which we've done with topical oxygen, or just apply topical oxygen, reduce that bacterial burden, reduce the biofilm burden present. Certainly doesn't qualify because it's not a Wagner 3 ulcer to go into hyperbaric. Hyperbaric, I'm going to use that in the Wagner 3 because I've got to drive angiogenesis by a lot of different mechanisms. Hyperbaric oxygen and topical oxygen are prescribed for different indications. And I think you understand the mechanisms and understand why they're not competitive, they're complementary. And they really are. They complement each other. And I can tell you that we use hyperbaric as well as topical oxygen. And I've never, until Cindy and folks like you said, hey, they're competitors. I never thought of them that way at all. And there are just also situations where hyperbaric is just not practical. I mean, we have a lot of chambers, and but sometimes it's not. I can't drive a chamber over to your house and treat you in the home. And so there are situations where I want to use oxygen, I want to prescribe it, but I don't have the right patient care setting, and that's important too. We certainly like to get all candidates into a center that is hyperbaric, but that's not always practical.
And would you consider those patients that maybe don't even qualify for HBO? Would you not disqualify them for topical oxygen?
Again, they're different indications. So,
Yeah.
if you look at the studies, the one we just finished one for, we just finished another randomized trial. We're getting ready to publish a meta-analysis with a group of docs. And if you look at that data on diabetic foot ulcers, those are Wagner 1 and 2 ulcers, and that's where topical oxygen has shown benefit. So, hyperbaric oxygen really doesn't, in my experience and in the literature, doesn't really have a lot of benefit in Wagner 2s, where its beneficial is 3s and 4s, in particular 4s. So they're different. I need this much oxygen, and I need it continuous for my this group of diabetic foot ulcers. I need this much oxygen with a different mechanism of action for my Wagner 3 and 4 more serious ulcers.
And are there any other wounds besides those DFUs that you believe would be treated well with topical oxygen?
Sure. I mean, we use it a lot in arterial ulcers. I mean, that's,
Mhm.
and again, I kind of stepped away from the literature a little bit. So just so you know, I went, so there's very good evidence for topical oxygen in diabetic foot ulcers, Wagner 1 and 2. That's very clear. We got 3 really great RCTs, and
Right.
that is outstanding. So, but however, where else do we use it? Well, just like everything, we're going to use it in other locations as well. I really like it for arterial ulcers, because HBO, from reimbursement perspective, you can't use on these arterial ulcers. And I've just found anecdotally that it works quite well.
Excellent. So when some of your colleagues tell you that they've tried topical oxygen, um, a couple of years ago and it didn't work, what do you say to them now?
Well, I think they need to look at what they used, because there were, in the early days, in the Jurassic period of topical oxygen, there were a lot of different types of ways to deliver the oxygen. Now, I think we've done most of our research on continuous diffusion, which seems to work very, very well, and the clinical trials bear that out. So 2 of those 3 clinical trials are on continuous diffusion oxygen, one on topical oxygen. And when you look at those devices, they're superior to what that was probably used, 5, 10, 15 years ago.
And knowing that research as well as the meta-analysis, which is, the golden ticket, if you will, if you were in front of CMS now making a plea to get that reimbursable code for Medicare on behalf of topical and continuous diffusion of oxygen, what would you say to them?
Well, so if you're Medicare and you've got a pie that's only so big with only so much money that you can deliver to your beneficiaries, you have to choose items, you have to choose devices and things that have good evidence. And topical oxygen's got great evidence. I mean, again, I mentioned we have 3 clinical trials, and we've got a number. Now we're going to have a meta-analysis and soon a consensus document on when and where to use it, a utility document. That's a lot of evidence. Most of the devices and things we use in wound care, to be very frank, don't have even close to that much evidence.
No.
And yet they are reimbursed. So when you get to that point, I mean, Medicare should follow its own rules. If you have evidence, we spent the time, money, energy to develop all this evidence, then you should get reimbursement.
Absolutely. And we're all in the business of healing.
Right.
And so if you can heal those patients with something that is that has proven, even in some cases, to relieve pain and heal these wounds, why wouldn't you? And the evidence points in that direction.
Yeah. And so I would challenge anyone who thinks they have enough tools in their armamentarium to treat chronic wounds. I mean, if you look at the US Wound Registry data, you're still only about 50% of DFUs and VLUs are healed at 12 weeks in the real world.
Right.
Clinical trials are better, but that's because it's a slightly artificial situation. But that tells you one thing: we need more tools. We need more devices, no more choices, and different mechanisms. We have a lot of CTPs. That's fabulous. We have hyperbaric. That's great. But we need tools. We need different tools, because one thing doesn't work on every patient, and
Right.
that's one thing we do know very well.
Exactly. Well, I truly appreciate your time, and I'm very much looking forward to that meta-analysis and the consensus document. I'm super excited for
excited.
all of that. And I'm jealous because it's in New Orleans. I grew up there, so you can see New Orleans in my background.
I saw Jackson Square. Yeah.
It's in my blood. So I'm thrilled that you guys are getting together in such a great city. So
we'll send you a king cake. So you'll all set to go.
Awesome. My trainer might not like that, but I will. So with that, I really appreciate your time, and I hope we can speak again at some point. And I look forward to reading the new research that's coming out.
Super. Right.
Thank you.
Thank you, Cindy.